I would like to invite Dr. Sankara Subramanian from Ranipet presenting Silencing the Snore, Surgical Management of Primary Snoring.
Good afternoon and all. My topic is surgical management of primary or habitual snoring. I'm sure at the end of this conference or any of the three sleep conferences which is going to happen in the next 2 months, at the end of each conference, I'm sure this one question will linger in everyone's mind. கொரட்டை கம்மி ஆகுமா ஆகாதா கொரட்டை கம்மி ஆகிறதுக்கு ஏதாச்சும் வழி சொல்லும். So I usually spend at least extra 10 minutes to my patients with whoever comes with the OSA or snoring. I will try to explain the need to screen for OSA, need to screen for snoring, etc., etc. So start with the European consensus has given the definition as snoring as turbulent airflow causing mechanical stress and vibrations in the soft palate, uvula and epiglottis. But more than the definition, the reason why this presentation holds some interest aspect and curiosity is snoring is as the social nuisance. I'm sure Dr. Mohan Kameshwaran has in one of the lectures mentioned 6 years before itself there has been a conversation in the Google whether snoring can be taken as a cause for divorce. And thanks to the movie industry, the last 2 years, many youngsters have come, they become anxious before just married or just after getting married, that whether their whether their spouse is snoring or not. And I'm sure that there is something called sleep divorce, where a married couple, they sleep in different rooms just because the partner is snoring. So this holds a social stigma as well. To start with, primary snoring is nothing but snoring in the absence of OSA. So no episodes of choking spells, no daytime sleepiness, etc. Just snoring. However, when it comes to the definition, there lies a confusion. So AHI less than 5 is generally considered as primary snoring. However, in some studies they say even mild OSA, AHI less than 15 can be considered also primary snoring. So as far as snoring is concerned, it is prevalent more in men than women and even in children also. Whether snoring is an hazardous thing, yes, some studies say that snoring independently can increase the risk of atherosclerosis, but however, some studies say the other ways as well. So, how can we manage? Of course, like any other OSA patient, a detailed clinical history is important, but a clinical history from the bed partner is much more important, because as we come to the next few slides, non-surgical management play an important role in the management of primary snoring. So positional therapy will be an important role. So partner's history will be important, and snoring characteristics. So for example, the classical snoring has results in the vibrations of the soft palate, whereas if the snoring is because of some other thing, some sound you can find the difference. So it's always better to have a recording or video recording from the patients, and of course any relation to alcohol intake, allergic history should be taken. As far as the diagnosis is concerned, apart from the clinical examination, the take home message will be, whenever there is snoring, you should suspect sleep related breathing disorder. And whenever there is a chance of sleep-related breathing disorder, you have to go for a sleep study. So the algorithm says that yes, after a clinical history, clinical examination, you suspect a sleep-related breathing disorder, you take a PSG, there is AHI is normal, and if there is snoring, then we go for the treatment. So snoring is not a disease. So only if the patient desires to have treatment for snoring, then we have to go for treatment. As I said, lifestyle management and positional therapy play an important role in primary snoring. With the advent of Instagram and Facebook, I am sure many patients will be asking whether we can use this nose strips. Yes, ask them to do whatever they want before going for any definitive management. Myofunctional therapy is often less discussed, but it plays an important role in primary snoring as well. And of course, always give an option of manual advancement devices or CPAP for primary snoring. So the principles of management is, yes, first come to a conclusion whether it is primary snoring or not, then go for the stepwise management. And always have a detailed conversation with the patient and regarding the management options, and then go for the surgery. So surgical aspect of snoring, most of the snoring surgeries involve the palate. So any surgery on the palate drug-induced sleep endoscopy is always recommended. And one of the reasons why DICE is important is this young patient, 22 years old, we have grade 4 adenoids, grade 4 tonsils, he had a pretty bad nose, he had sleeping disturbances, snoring, etc. So we did a DICE, as you see, there is no collapse of the palate. So, but when you go inside, the sound was caused by the secondary collapse of the epiglottis. So, as Dr. Sanu said in this previous lecture, so just by doing a H-mark maneuver, the airway opened a lot. So, if this patient, if he had done a very good nose, you can see the airways open with just by H-mark maneuver. So, in this patient, if you do a very good adenoidectomy, very good tonsillectomy, if we correct a nose also, there is a chance that still he might have this problem. So, post-surgery, we may need chin strap or jaw strap or sometimes manual advancement devices as well. So, again, this interesting thing will be, I am sure every one of us would have faced a patient with snoring. He would have got a deviated septum or a turbinate hypertrophy. We would have done a septal correction and a turbinate detection, and patient would have felt lot better. Yes, but long time results as far as the nasal surgery as a single surgery for snoring, the results are inconsistent, and most importantly, sometimes nasal surgery alone can aggravate the problems or the snoring. And of course, in OSA, the nasal surgeries are defined as functional airway nasal surgeries, where we go for the septal cell body correction or the turbinate correction or the adenoidectomy. That's okay. But this patient had a 23 years old female, AHI 23, grade 4 tonsils, grade 4 adenoids. Since she was having a moderate OSA, my dilemma was whether to go for a palate or not. Being a young patient, so and there was a severe static obstruction. But what happened was when we put when we did DICE, you can see there is no space at all. There is in fact we cannot even pass the scope. But when we advanced the scope and we were able to look for the epiglottis and the oropharynx level, and just by doing a Schmack maneuver, again the collapse started. So she had a grade 4 tonsils, and there was a tonsillar collapse. So I was pretty much convinced that by clearing this mechanical obstruction, she will be getting a lot of improvement. But again, like previous lecture, Dr. Sanu said, we did a DICE by putting a nasopharyngeal airway. So we nasopharyngeal airway, through the tube we put a scope. So he said that by doing this, we are bypassing the nasal. So if we had corrected the nose alone, she would have got this epiglottis collapse. So what was not happening before, by doing diagnostic endoscopy through the nasopharyngeal airway, she was having an epiglottis collapse. So this would have aggravated the condition if we had done the surgery. So as far as the palatal surgery is concerned, as I said, 70% of times the palate is the culprit, and most of the procedures for snoring are targeted on the palate. Various options are there. Most commonly performed is the radiofrequency ablation. I personally use the coablation using the Reflex Ultra SP1. So these are markings. The first point is the midpoint between the hard palate and soft palate junction, and the 1 centimeter distal to the midpoint, we introduce the wand. We look for any resistance, and we press the ablate button for 10 to 12 seconds, and similar points in the para-median sides will do. And we can go for 2-3 times, and sometimes along with this we go for the uvula as well. And we should mainly look for there should be no blanching or no any abnormal bleeding. So in that case we should stop the procedure immediately. And this takes at least 2 weeks to have the effects, and already preoperative findings, preoperative counseling, we would have counseled the patient that we may need 2 or 3 sittings for this procedure. And one good thing is this can be done as a OP procedure as well, under office-based procedure as well. We have to just make sure that adequate analgesia and patient is comfortable throughout the procedure. Injection snoplasty, personally I don't have any experience regarding this, but it uses sodium tetrahedral sulfate or a combination of lidocaine and ethanol. Barb depression laryngoplasty, so this procedure is not the primary treatment or the treatment for snoring. So this procedure is done on 2 conditions. One, we have to be, first the condition is patient is not ready for any other methods for snoring. He is not interested in CPAP or is not interested in radio frequency or anything. Second, the surgeon must be 100% sure that palate is the only reason for snoring. So under these conditions, we go for a barbed pharyngeal. It based on 4 principles, that is lymphoid tissue excision. So we excise the tonsils, we preserve the mucosa and adipose tissue. So this is the supratonsillar area. We ablate the supratonsillar fat for the vector. And fourth is the muscle suspension. So we suspend the palatopharyngeal muscle to the pterygomandibular raphe. So we use the barbed wire 2030 absorbable suture. We start from the midline. So that's a procedure. So the thing is, this again I said that this surgery is not the primary treatment for snoring. We have to be very much sure that palate is the only reason for snoring. The basic thing is this barbed reposition pharyngoplasty dampens the vibrations of the palate. As I said, isolated epiglottis and tongue base collapse causing primary snoring are rare, but we should not ignore that. As far as the pediatric management is concerned, as I again, AHI less than 1, if the child is snoring, is considered as pediatric, primary snoring in pediatric. We have to exclude the allergy, sinusitis, narrow maxilla, all the things, and then if it persists, we should think of adenotonsillectomy. Even after adenotonsillectomy is persists, then the algorithm is changes. So to summarize, primary snoring, still universal consensus on the exact definition of primary snoring is not yet well established. As far as the diagnosis is concerned, drug-induced sleep endoscopy will help us at least at identifying these sites, and you will be hearing this sentence for the next 2 days or next whatever lectures for OSA. There is no one size fit all for in case of OSA or even in snoring. It all be catered to the patient depending upon the surgeons, depending upon the locality, depending upon the facilities available. And of course, as far as the management of primary snoring is concerned, it's always a stepwise progression is mandatory than jumping into a drastic procedure. So thank you one and all for your patient listening.
Good presentation, Shankar. One question from me. So you've been doing these surgeries for the past few years, right? The sleep surgeries. And how many patients, or in children especially, if you do any palatal procedure?
Palatal procedure? Not yet, sir.
Not yet, okay. In adults, when you do any palatal procedure, is there any, eustachian tube dysfunction that's happening post it, or any velopharyngeal insufficiency that you have seen in your patients?
Palatal surgery causing eustachian tube dysfunction, sir. So far not yet.
Not yet, okay. And in adults mainly.
Yeah, adults
what about VPI?
Sir, I'm performing only the barbed sutures, so no.
We don't see much.
Yeah.
That also no issue.
Yes, sir. Thank you.
Thanks. Good one.
A good presentation, Shankar.
Thank you, doctor.